It is irritable bowel syndrome.
Okay.
That's this one.
But that can be classified as...
Just the general signs and symptoms I gave you are considered irritable bowel syndrome.
Okay.
And the giveaway is the anxiety, depression, and the 3-month thing. 3 months with diarrhea and constipation and bloating, and it's recurring 3 times in a month. That's the signs and symptoms. That if you're getting that all the time, then it's constant, and it's irritable bowel.
Okay.
Because you're shitting like crazy and stuff. I just said that out loud and I'm recording this. Okay.
Other stuff for 100.
Okay, the nurse is preparing to assist a client who is able to transfer with 2 assistants from bed to chair. The nurse requests assistance from staff members, but no staff members are able to help at this time. Which action by the nurse is the most appropriate? Let me read these out to you because they're hard to see, obviously. Ask the client's family member to assist with the transfer. Assist the patient. You can see this one. Assist the client to transfer with the aid of the nurse and a walker. Use mechanical lift to transfer the client from the bed to the chair.
Well, it says no other staff members are able to help.
Yep, no one else is there to help you.
So, well, you would need 2 people.
Okay, you can't put yourself at risk to do this, right?
No.
Okay, you can't put the family member at risk to do this.
So you would use a mechanical.
You'd use a mechanical lift to get them out of the bed because they don't have the ability to get themselves out, or you wouldn't need the assistance, right?
Yeah.
That's the answer at C. So that's why those are just, some of these are just general. They have nothing to do with unit 5, 6, or 7 or whatever. They're just NCLEX style questions to get you warmed up to be thinking through there. Okay? So the thinking is you can never put yourself at risk. You can never put a family member at risk, right? Liability says you just can't do that.
Yeah.
You don't want to hurt yourself because this person's 328 pounds diabetic who can't get out of bed. Okay, you need 2 other assistants and yourself to get them out.
Yeah.
That's the giveaway right there.
The walker's not going to do
The walker, they can't get themselves out. So even having a walker, they're going to do anything for them, right?
Yeah.
Okay, so you have, at that point, you have to use a mechanical assist to get them out. Okay, ready? That's the next one.
Other stuff continued for 200.
I precede arteriosclerosis. What am I?
Well, arteriosclerosis is the... No, it's the lumen occlusion.
Yep, lumen occlusion is arteriosclerosis. What has to happen before that starts? Before any building can be built, what do you have to have laid down first?
Oh, like the...
A hard foundation. What's the definition of arteriosclerosis? Laying down of a hard foundation. So in order for arteriosclerosis to happen, what has to precede it? Arteriosclerosis. So I am what? I'm arteriosclerosis.
Okay.
So that's what you have to precede arteriosclerosis.
Okay.
So arteriosclerosis. Okay, what's next?
Other stuff.
The primary health care provider prescribed adenol at 0.05 grams orally. What is this patient taking this for?
Those are the...
You don't have to be that specific. What are they taking this for?
Yeah, I'm trying to think of
What's the overriding arching thing why anybody would take any of those 4 classes of drugs that we talked about? We've already started talking about them. So why would anybody take an alpha blocker? Why would anybody take a beta blocker? Why would anybody take a diuretic? Why would anybody take a calcium channel blocker? What's the overriding thing they're taking all those medicines that are there for? It's not inflammation. Think about what section of the book of our notes it was in.
Cardiac.
was cardiac.
Okay.
So that narrows it down. There's only 2 reasons they could be taking this.
Is it lower or higher?
Yep, either they're going to try to higher the blood pressure or lower the blood pressure.
Okay.
So all the drugs in the ABCD categories were all doing one thing, treating what thing? They were treating hypertension. So OLOL is what kind of drug now? What class is it in that group? It's beta blockers. That's right. Okay. So that's a good question.
Yeah.
Because you had to think about it. You had to think about, okay, it's treating hypertension. It's one of my ABCDs, and then it's a beta blocker. But the question that I'm asking here, that I built this to be, was just hypertension. You just didn't know what class is it. And you had to know OLOL was one of those guys. You didn't even know how detailed it was. I mean, you kind of figured it out, right?
Yeah.
But you had to understand those are hypertensive drugs, okay? Why do we have so many drugs that treat hypertension and so few to treat hypotension?
Because hypertension is more true.
There is one system to raise blood pressure and 2 or 3 that bring low blood pressure up. So we have other systems that bring blood pressure from up. So we have posterior pituitary, we have A2, and we have aldosterone. So we have all 3 of those systems that bring blood pressure up. We only have 1 that brings it down. So we have all these drugs to bring hypertension down. And all those guys, by the way, only do one thing. They just shut down elements of the RAS system.
Okay.
So these drugs just shut down those elements of the RAS system. So I think beta blockers shut down the beta receptors in the lungs and allow ACE not to be produced.
Okay.
If ACE isn't produced, what's going to happen? It's going to force the blood pressure down, because guess what? A1 can't go to the dance club and get charged up and be A2 or aldosterone. Okay. Don't quote me on that last piece, but I think that's what beta blockers do. Okay, we good?
Yep.
Okay, that was a dang good question, because it made you really think through it. Okay, keep going. What's next?
Let's do Unit 6, 100.
What is the word for when alveoli cannot expand? You got it. Good job. Good job. Okay. When you hear that noise, it means you got it right. When you hear the it means you got it wrong. Okay, keep going.
Okay. Unit 7, 300.
Name the 3 types of renal dysfunction.
Is this the glomerular?
Those are specific diseases, the types of renal dysfunction. There are only 3.
Oh, like the pre, post. No? Yeah?
You're on the right track, yeah.
Okay.
There's one more. You got 2 of them. You have to name all 3 of them.
In the middle.
So intrinsic, but that's correct. So pre-intrinsic and post-renal dysfunctions. Okay. And then all the diseases deal with all that crap.
Yeah.
Like renal caniculitis, kidney stones is post, right?
Okay.
Where if you have like glomerulonephritis, that's like lack of blood. ATN is lack of blood getting into the lack of oxygenation, right? Where pyelonephritis, UTIs, those are actually damaging the structures intrinsically. Okay. So keep going. You're doing good.
Okay. Let's do Unit 7, 100.
What are the 2 categories of renal tests we can
Blood
run?
and urine.
There we go. Good job. You're getting warmed up now. Good job. Okay.
What's poopery?
It's just, I just made it funny making that name up. They're just general questions like the other ones, other stuff.
Okay. Let's do that for 200.
Okay, the nurse is analyzing what lab values that were prescribed to determine nutritional status for an older adult client. Which lab values would be of concern?
Okay, I'm good at these.
So sorry, this is really hard to freaking see, and I'm not sure why.
A is fine.
Let's see if I can make this small. I can move that way, you bastard.
Is there a D?
Yeah, there is, and I'll read it out to you. So A is hematocrit of 42%.
Which is fine.
Okay, calcium of 10 milligrams per deciliter.
Which is fine.
Okay, bun is 20 milligrams per deciliter.
Fine.
The last one is hemoglobin of 8 grams per deciliter.
No, it's supposed to be 12.
Okay, yeah, it's 12 to,
16.
yeah, you got it.
I finally learned the things today for Sodium, potassium.
Oh, our little.
Yeah.
Okay, keep going. You're doing good.
Other stuff. Continued 100.
What do we call a pinpoint hemorrhage of small capillaries?
The
You're right there. It starts
I
with a
know.
P, but it's not.
I know, but it's like Peter. No.
You're right. It's Pete something.
P.
Petchiae. Petechia.
Petechia. I knew what it was though, because I.
You were like.
I knew it was Peter or something.
Peter Pumpkin Eater. Okay, keep going.
February 100.
February for 100. The nurse reviews the most current laboratory data for the 4 clients to whom the nurse is assigned. The nurse should first assess the client with which lab value. I don't know what 3 is. Oh, that's red blood cell count is 3. Potassium is 5.0 millicochleans per liter. Hemoglobin is 11.8. So is red blood cells going to be good at 3?
Well, it's normally 3.6.
Okay, I just screwed this one up. It's not A. It's not that one. Just throw that one out.
Okay.
But potassium is 5.0. You said you just learned the electrolyte, so is that one right?
Potassium is 35 to 45, or 3.5 to 4.5.
I think it's 3.5 to 5.
Oh, really?
Yeah, potassium's not. It's not a 0.5. It's a weird one. We'll look it up in a minute, but it's not potassium.
Yeah, that's actually right.
Okay, so then hemoglobin is 11.8.
No. Right? It's supposed to be 12.
Oh, well, okay. Well, the next one. Okay, look at the next one. Okay, so remember it said which is the one you should assess first. So 11.8 hemoglobin, right? That's not good. It's a little bit below what it should be, right? Okay. The next one is platelets are 40,000.
Oh, that one.
Yeah, that's going to be the right one. Why is that one the bigger one?
Because platelets is.
It's way down.
150 to
400,000, right? So that one's way down.
Yeah.
Where hemoglobin is low, but it's not as dangerous as that other one, right?
Yeah.
Platelets, there's something definitely going on. Okay. Okay, keep going.
Other stuff, 200.
Which meal selection would be the most appropriate for the nurse to deliver to the Mormon client? Waffles, bacon, fruit, and coffee. Steak and eggs, toast, fruit, and coffee. Scrambled eggs, hash browns, fruit and green tea, or sausage and cheese omelet, muffin, and orange juice.
That one.
Okay, that's correct. Remember all those Jewish and the Muslim diet and all that stuff. There was one in those flashcards that I was using. That was this one, and so I was like, okay, everybody can answer this one. So I just threw that one out just to be funny, and I gotta fix this. Okay, keep going.
Unit 8, 300.
Unit 8 for 300. Okay, what disease has these signs and symptoms? Epigastric pain, 2 hours after eating. It is also relieved with food when they eat, and an upper GI bleeds is also associated with it.
That one is
Epigastric pain, 2 hours after eating. It is also relieved when they eat again. When they eat, it relieves it, and they can get upper GI bleeds.
The nurse, this is the one where she frequently gives them snacks.
Yeah.
Which is.
Well, GERD, what is GERD? Does GERD relieve with food?
No.
So it's not GERD, right?
No.
Okay, so what was the other ones?
I need can you give me 3 of them?
Well, there's peptic ulcer, there's irritable bowel, there was carcinoma. There's carcinoma. How are you doing, Amy, Elizabeth? It's carcinoma. So the one that's relieved with pain after eating is peptic ulcer disease. Yeah. Okay.
What's the one that's
That's going to be GERD. GERD, you get it within a half an hour after you eat, and then also there's like pancreatitis. wouldn't be relieved for eating. Why? Because it's trying to push, and then also cholecystitis isn't going to be relieved with that because it's trying to push bile into the duodenum, and it's because of blockages in those systems. Those are going to be aggravated with eating because you're going to try to push stuff through there, and it's not going to work. And then liver disease, like liver cirrhosis and stuff, is going to be aggravated with eating because you're going to want to produce bile in those juices, and if they're blocked, it won't let them out, and it's painful. Okay, pick another one. I just built this Jeopardy game, and we're going through it.
February 300.
Poopery for 300. Okay, here we go. And Amy Elizabeth can now answer. Oh, it's a daily double. Okay, 1 point, 20 points. There we go. The nurse is caring for a client who is retaining CO2 due to respiratory disease. The nurse anticipates that the client's pH will be which value? 7.30, 7.50, 7.70, or 7.88. You can't see it for some reason.
7.30.
Why is it 7.30?
Because it's more acidic, and CO2 increases acidity.
Okay. Good job. Okay, you got the board then, Anne Marie, and Amy Elizabeth. Blah, 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 blah.
There's like 7 names there.
Amy Elizabeth, you got the board.
Just go with it.
You got the board, killer.
400. Wait, no. 500 other stuff.
This causes brain diseases in humans and animals. What am I? I'm a mutated protein.
Yeah.
That is correct. Good job. Okay, you have the board.
Other stuff continued 300.
Okay, here we go. The splitting open of a surgical wound, a wound that has been closed or sutured closed, is called what?
A splitting open of a surgical wound is
A wound that has been sutured closed is called what?
Yes.
You're close. Dissonance.
Dissonance.
Okay, you have the board. Go ahead, Addison.
I did it.
No, no one got that one, so let's keep going. Are we counting that? Did you really know it? Okay, I was like, did you really know it?
I could see it. I just couldn't.
Blah 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 blah. Say it. Okay.
I'm a visual person. Like
okay.
I could figure out what.
This lets me add pictures and stuff to it, but it just takes time. I didn't have time, so I apologize. I normally add audio and video ones. I'll add like the sounds of like auscultating lungs on these, but I just didn't have time. It just takes time to do it. I just didn't have time.
Okay, poopery 400.
Poopery for 400. And poopery is being funny. It's not really poopery. It has nothing to do with poop. Okay, the nurse is analyzing lab report for a client who had specific gravity determination drawn. The report indicates a value of 1.032. The nurse understands that the condition, which condition may potentially cause this result: renal disease, diabetes insipidus, decreased renal perfusion, and then D is the inability of the kidneys to concentrate urine. This is a pretty complex question.
The nurse is analyzing high. The nurse understands that which condition may potentially be causing this result. So if there's a lot of solutes, if they have diabetes insipidus, that means that they're peeing a lot.
Yeah.
So they would have very low solutes.
Yep.
Decreased renal perfusion means that they don't have blood circulating to the kidney, so they would be peeing less. Renal disease could be a possibility. What's the last one?
Inability of the kidney to concentrate urine. It's not that one.
No, it's very complicated. So it would be A?
It's actually D. Decreased renal perfusion causes this.
Oh, let's see.
That's C. Yep. Decreased renal perfusion. The reason that it's
because then there's not very much blood, so then you get less volume. So there's less things for it to put the solutes in.
Yes, and also, so you hear me every time. I did not choose this question. This is an NCLEX practice question, but that's why I keep telling everybody to understand what specific gravity is, because people are just memorizing stuff around it. They don't understand what it is. And as we know, you get caught with your pants down when you don't understand what it's asking. So specific gravity is urine relations to water. So when you have more, and you were going down the right trail, when you have more solutes in relationship to the water present, then you get higher specific gravities, a larger number than our normal values. Okay, so that you did awesome. Okay, good, thank you. But that's the correct answer. Okay, keep going. Who got the board?
Yeah. Oh, okay. U6 for 400.
Okay, the patho of this disease is impaired chlorine and sodium reabsorption. Although it affects the lungs.
Cystic fibrosis.
Thank you. That's correct. It is cystic fibrosis.
Because it causes like a lot of mucus because
It's an autoimmune disease, so it doesn't just.
The water is following the sodium, which is following the chloride.
Yep, there you go. Okay, we're going next.
Oh, me?
Yep, you got the board still.
U7 for 500.
Name 4 of the 6 functions of the kidneys.
Oh, just pick 4?
Just 4 of the 6?
Okay. Ion balance, production of erythropoietin, waste management.
What's waste management called? It has a name.
No, it's not excretion, is it?
So you got, which 2 did you get? Say the 2 that you got already. So erythropoietin was 1.
And then ion balance.
So ion balance would be acid base.
Yes.
Okay, acid base balance. Yep.
Renin.
Release of renin is the other one. One of them.
That's 4 then, right?
What was the other one you did? Filters blood. So here are the 6. Filters blood, controls blood pressure, acid base balance, makes erythropoietin, releases renin, and activates vitamin D. Those are the 6. Okay, what's next?
You got that one, so it's your turn.
Let's do other stuff. Continue 400.
Is there any way we can turn down the heat in here?
Just crack the door open. Yeah, I think the heat's as low as it's going to go. The only thing I know works in here is the lights.
It might be because I was just running all over the library.
Yeah, we'll just be a little bit more quieter. So for ozamide, it belongs to what type of hypertension drug?
Oh.
Anyone? A what? I don't know what A is.
The AB.
There's A, B, C, D's. Yep, it's D. It's a diuretic. It is one of the diuretics. Good. And Amy. Okay, who's next? Pick one. I don't care who picks one.
U8 for 500.
Name all 3 types of viral hepatitis, how they're transmitted, and if they have a vaccine.
Okay. Hepatitis A is foodborne. And yes, vaccine.
Mm-hmm.
Hep B is blood or body fluid borne vaccine.
Yep.
And Hep C is blood and body borne and no vaccine.
That is correct.
Is the one that's very commonly sexually transmitted. Most likely.
Well, yeah, C and B can both be sexually transmitted, but yeah.
No, they can, but they say that the most common way that people get Hep B is through sexual transmission.
Yeah. Good job.
I don't know why, but that was in red on the stupid outline, so I think it's important.
Okay. Pick another one.
Ooh, poopery for 500.
Poopery for 500. And like I said, these are just funny. They're not actually all poop based. Okay. The nurse educator is conducting a teaching session on the types of dehydration. The nurse describes one type as water and dissolved electrolytes being lost in equal proportion. What type of dehydration is being described? Isotonic, hypertonic, hypotonic, or intracellular?
Oh, it's isotonic.
It is isotonic. Why is it isotonic?
Because they're moving across the membrane at equal proportions, so they're the same on both sides.
Yep. Congratulations. Good job.
Other stuff continued.
Which cells are affected by Hodgkin's lymphoma?
Reed-Steinberg?
That is correct. Reed-Steinberg cells are present, and it's B cells that are affected.
Well, are B cells on both?
B cells are on both.
Okay.
The non-Hodgkin's lymphoma is both T and B cells are affected.
Mhm.
On the Hodgkin's lymphoma side, it's B cells, and then Reed-Stromberg cells are present. That's what they. That's the exact answer. But it's B cells only on the Hodgkin's lymphoma side. Okay, good job.
No, I appreciate you going through the whole answer
No, that's why we're doing it.
it's good. We went over that section for so long
What
ago.
the
It feels
hell?
like.
Battery low. Why's my battery low? Oh, that battery's low. I must have plugged this bastard into the wrong thing, which I probably did. Oh, yep, I did. Whoops. Let's get out. Here we go. Okay. We're going to go to commercial break, Alec.
So are we gonna review the other section now? Or
We can't. These are just review of everything. And it was more fun than just sitting and reading a damn PowerPoint slideshow thing, than just going through systematically reading the review thing. I can't do that for 2 hours again.
oh, okay.
It made me a little bit crazy yesterday because it was just like,
Oh, okay.
you know, I have to make it a little bit more fun once in a while.
No, I like the game.
Yeah, no, it's just like I said, it
I
was
felt competitive. I was about to just give you both the elbow. I was very tempted.
Hey,
You're
yeah,
so
there's
lucky
much-
that you're.
Oh, there it goes. It's working. It's working. It's back on.
You're so lucky
It's
that
still
thing ran
working.
out of
It's
batteries
working.
because you guys are about to get it.
Yeah, no, you're good. You're good. No, like I said, I think the competitive thing, it sounds pretty cool. Okay, there we go. I was thinking, trying to think. It's like, hey, I've never had this run out of batteries before. That's what happens when you plug it in. When you plug it in, freaking. Okay, turn the lights on. We'll just keep going. Okay.
I desperately need to go over liver diseases.
Okay.
Unless we're gonna go.
Yeah, we can do that. We'll get out of this stupid thing. Oh, it's working now again.
Is there a section that you particularly want to cover?
I can just bring up that slide deck that review sheet and make sure that we just get everything on there because that's right from the review sheet that she built, and I'm happy to do that. So let me get out of it.
Yeah, we
You
should do
didn't
that.
meet yesterday, right?
I didn't.
We met at the library, remember?
I met you, but I was.
Yeah, Addison
Yeah.
wasn't there.
Okay.
Okay, give me 1 second to bring
So
this
you're
up.
Addison.
Yes.
Adriana was
Yeah.
like, "Oh, Addison." And I'm like, "I don't know that."
She's not here.
I had to work.
So I think we'll just
It's really
kick
good to
off
meet
where
you,
we're at.
Elizabeth.
Nice to meet you too.
It should be on.
Out of the 20 names you said, it's Amy and Elizabeth.
Yeah.
Yeah, no, I apologize. It's Amy Elizabeth. That's her name. I feel really bad now.
No, but we're gonna. No, don't feel bad. I'm teasing, but I really like. I give people 2 names versus like 1. I don't blame you for.
I'm just
gonna make it harder.
I said
Here's 2 you have to
your name
remember.
wrong. Sorry. Okay.
But he did remember that I had 2 names. Like the first time that I came to
I
study
don't
group,
remember your name.
he was like, "Are you like Anna
Or turn the
Marie?"
we turn the lights off. I can't. This is my cheap little projector. It doesn't work. I mean, it works a little bit better, smaller, but it's not as bright. So it's harder to see
Do we
it.
have any drivers?
Did she put
Yeah.
this online?
Yeah, that's where I got it. It's on the PowerPoint.
Oh, okay.
It's on the. Oops. The problem loading your pages. What the heck's the problem with loading the pages? How about you reload them then? Piece of crap. What the hell's wrong with loading my pages? Okay. Is it freaking
Are
screen
you guys both
tracked?
comfortable with the digestive system, like all of it, or?
Well,
I know that
I'm just reviewing everything, knowing that at some point there's like 28 pages worth of crap there, and it's just going to be, you know what I mean? I got at some point you just got to say, well, I know what I know.
She's gonna do the majority of it on the new stuff.
Yeah, on new stuff.
So half of it on the new stuff, and then half of it on everything else that we've done.
Mhm.
So here we go. There it is. Okay. What's this one? There it is. Okay, Unit 8. Here we go. Okay, so let's just go through it. So gastroesophageal reflux disease is caused by Addison. I think you know this one.
That was the reflux or the acid.
Yeah, it's acid based, but what causes that to happen? There's any reason that it happens.
This is GERD. Yeah. We just went over this.
Yeah, that's what we're doing. Yeah, it's on the cheat sheet, so we'll just do it again. Okay. Now I'll cop back up with this. So yeah, just basically the cardiac sphincter in the stomach is weak,
Yeah.
and it allows gastric juices to flow back up into the esophagus. What are some of the things that are a problem with that? Why is it a problem?
It could destroy the esophagus.
Yeah, it actually destroys the tissues of the esophagus, and it's a precursor to cancer of the esophagus, right? And then it can also flow further up, and it can get all the way up into the larynx structures. They can cause you to breathe that stuff into your lungs. I don't think any of us want to breathe gastric juices into our lungs. That would not be good. Okay, then it says here that it can cause electrolyte imbalances. Why would this cause electrolyte imbalances? You're throwing up acid. You're throwing up the contents of your stomach, and so it's going to throw all that process off. Okay, and then obviously it says here tissue erosion or esophagitis.
Sorry, just because this one's in bright red,
Yep.
it's also can cause the electrolyte imbalance because a lot of people that have the heartburn, they're doing Thomas and other things, and that makes it extremely basic. So it's like if you're constantly treating it with symptomatic treatment, so it treats the symptom, but it doesn't treat the underlying problem, so you end up causing a problem with your balance.
Okay.
Because Tums are they have a lot of calcium.
Yeah, calcium, magnesium, and potassium. Depending which brand you use, they have different stuff in them, but that's what happened.
So that would be causing it to be more basic.
Yeah. So it's like you have one problem and you're trying to treat the symptom of it, and then you cause another problem, which is the
And just remember that the way that's making you more basic, the reason it's making you more basic is because what's the little symbol behind all of our electrolytes? It's a plus symbol. Calcium plus, sodium plus. So you're just adding more pluses, and if you have more pluses, that means
Basic.
Yeah, you're gonna be more basic. Okay, here we go. So, and then pains and so signs and symptoms. This is the key to remember which ones these are. So we talked about the one that was peptic ulcer and IBS, right? So gastroreflux, gastroesophageal is pain is 30 to 60 minutes after eating. That's the big giveaway, right? It's worse when bending over and lying down. That's because the juices are allowed to spill back up, and then it just stay up right after eating and sleep with your head elevated. Don't be eating high protein, low fat diet.
do we have berries?
Yeah, I got some.
Okay. Because I have like two things that I had to contribute, but they're for later on.
So how would they fix this? Just like.
Well, take it like so. How would you fix this? So you stop doing this, right?
So is it a higher protein, low fat diet?
Yeah, higher protein, low fat diet. You're going to give them You're going to have an anti-acid therapy, but you're going to monitor it, right? You're not just going to be doing it at home. You're going to give them medicines that are a little bit more aggressive, and then you're going to allow it to heal. By not keeping the reflux happening, it's going to allow the sphincter to heal, and then it's going to allow those esophageal cells to heal.
Okay.
The other way that they treat it is there is actually a surgery for this. If it just keeps happening and they can't stop it with that treatment, then they'll go and they'll actually repair it.
Okay.
And it's called like a gastric something. It has a name. I don't. If I see the name, I'll know it. But if it's whatever the test, I'm going to see the name. I'll know what the heck it is. Okay. So what's the next thing we got here? So important pain can mimic heart attack. What's that?
A Nissen wrap, a fundoplication.
There it is. Yeah, that's what it's called. It's like a lap. They basically lift it up and they put part of the stomach and wrap it around the esophagus and tie it up.
So if you see something that's a Nissen wrap, or that starts with fun, because it's fundoplication.
Well,
like that doesn't sound fun at all.
The top of the stomach is called the fundus. That's why it's called that. Okay. Yay, how much fun is that? That's so exciting.
How much fun is that? Super fun.
That sounds so exciting. Okay. So the next thing is hiatal hernia. So what's a hiatal hernia?
It's a mechanical problem because basically your stomach is sticking out over your diaphragm.
Yep, stomach stick out through the diaphragm. It's herniated, right? It's moved forward. And what are the big problems with that? Well, if your sphincter closing is getting support from the diaphragm normally, and it's now sitting above the diaphragm, it's now weaker. So you're more apt to get GERD. You're actually more apt to get GERD, or GERD and hiatal hernia basically exist together. So you may get GERD symptoms. A lot of times we can't diagnose a hiatal hernia, but when we go and scope for GERD, right, the doctor, oh, wham, bam, thank you, ma'am.
No signs and symptoms.
Yep, no signs and symptoms.
That's what I was like, I don't know. I don't know what the problem with it is.
We detect it with a scope, right? When we go do a scope, a gastroscope, that's when we see a hiatal hernia, and the doctor just fixes it. Okay, peptic ulcer, and then by the way, caveat, if they're having chest pain, what do we always tell them to do? It's a heart attack. Yep, treat it as a heart attack and get care. Okay, don't wait it out. Go get help. And I'll just say that each time just to remind us, okay? Because I know dang well we're going to see that tomorrow. I know we're going to see that. Okay, peptic ulcer. This one was different pain associated how with eating. We just did a question in it.
That you see it like hours.
It's 2 hours after you eat, and this one is relieved from eating. So if they're getting pain, they'll eat again, it'll relieve the pain.
And then this one's usually caused by bacteria.
Yep, it's a bacterial. H. pylori. And Sandra was supposed to look this up, but the funny thing about this is we used to think for years and years and years and years and years that this is just because you didn't take care of yourself and you ate shitty, salty, nasty, hot food, right? It was this scientist, I can't remember his name, I'll have to look it up, but he basically found the H. pylori bias and we're like, no, it's this, or this bacteria. He's like, no, it's this bacteria. And no one believed him. And so this doctor, it was like in like the 1960s, man. It was like just recently. It was like, it wasn't a long time ago. He drank the stuff and got ulcers and was like, I told you it was this stuff. Because he was a young, healthy guy, right? Wasn't overweight. Didn't eat spicy, nasty Mexican food and stuff, right? He got normal stuff, normal, just non-acidic food. And he still got peptic ulcers. And so he proved that it was H. pylori.
Okay, so something that took me a while to figure out, like, I don't know if anybody else had this problem, but just in case you guys also had this problem, because this one's an ulcer disease, and there's an ulcer, there's two other basically ulcer diseases associated with the intestinal, well, the GI tract, that we have to learn for this section. The way I distinguished it is that this one is infectious, and the other ones were inflammatory and autoimmune problems. So in case that's helpful for anybody else, because I was sitting here. That's exactly why
we're here.
I just, because I was sitting here and I every single time I would remember that both of them had ulcers. I just couldn't remember which one had which.
Yeah, one's bacterial based and one is inflammation and autoimmune based, right?
Yeah. And then so for this one, you would need to do a combination therapy of antibiotics and acid suppressant medication.
Allow the stomach to heal.
I don't know if that was helpful for anybody else, but it took me a minute.
So what was the other two that had ulcers? Was it Crohn's? Or is ulcer colitis?
And
Crohn's.
But both
Crohn's
of those
is
are
autoimmune. Oh, okay, yeah, they're both under the autoimmune umbrella.
Yeah, they're both inflammatory bowel diseases.
Okay. Yep.
So it's inflammation, which is your body basically trying to, overreacting, is what those two both are.
Okay.
And then I also have a small diagram of ways I remember.
Okay, none of your diagrams are small, Amy Elizabeth.
My diagrams are quite small. This only takes up 1/3 of the page. Thank you.
I'm teasing. Because none of us can draw like you, and so we're all embarrassed. We all don't have any artistic ability at all. So we're all just jealous that you can draw that good, basically. That's what I'm basically saying.
And we later find out that she's a famous artist that sells her paintings for millions and millions of dollars. Thanks. I'm over here embarrassing myself.
Addison's nice. I know that for sure. She's very funny and she's very nice to people. I don't know if she can draw or paint, but I know she's nice. Okay, so ulcers, signs and symptoms of a GI bleed.
Oh, I have. Well, do you guys have any trouble remembering any of those hematocysts?
Hematemesis. Yeah, hematemesis or hematemesis, and what is that?
Hematochezia.
That's blood in the bottom. That's blood in the vomit, right? And there's two kinds. There's bright red and there's coffee ground style. So which one's more dangerous? Which one are we more worried about?
The coffee ground.
No, in upper GI bleeds in bloody vomit.
No, it would be
it's the bright red blood we're the most worried about because it means the damage is closer to the airway. Okay. It's closer to the airway, but on the butt end, on the lower GI bleeds,
we'd be more worried about
the coffee ground blood. Why? Because stuff near the bright red blood's near the opening, right?
Yeah.
And that's hemorrhoids and stuff. No one dies of that, right? Yeah. But upper GI bleeding, the coffee ground and the melena, bloody crap, that stuff's up in the upper GI, and there's something going on up in there. That's definitely more of a serious condition, and we're worried about that, right? So again, it's on which direction. Upper GI bleed, red blood is more of a condition that we're looking for because it means the damage is closer to what?
Opening.
The airway. So that could be ABC conditions, right? We're now worried about them occluding their airway. But on the other end, on the pooper end, bright red blood's not a big issue because nobody dies from bleeding by their sphincter. What I mean? No one dies of hemorrhoids. No one dies of anal fissures and stuff that what causes that. But the coffee ground, melony, like digested blood means there's something going on up in here, and that's a heck of a lot more serious. Where coffee ground blood in the stomach is serious, but it gets part of the digestive system, we just vomit it straight out, and so it's no damage up in the upper part. We did. Is that did I answer that or? I was going to say, do you have more to add on that?
I had a diagram. If anybody needs if anybody wants a diagram, just
you can draw the diagram. Go ahead. Go ahead.
Here's the thing, like I'm a visual person.
No, you're fine.
So
you
like
can
as
draw
long
it.
as I can picture it, I can remember it on the test.
No,
but if
you're
I
good.
can't picture it, I can't remember it on the test.
Please, hey, Addison, will you turn the lights on so she can draw it up there?
I don't think I'm going to draw it up there because this one's one of the color coordinated ones.
Color coordinated. Yeah, I only have the red marker there. I'm sorry.
No, you're good.
And by the way, the reason this is like that so you can see if it's full or not. It actually goes empty.
I thought that
you
was
can
cool.
see it. Yeah, you can see it because I hate going, this is crap, and you don't know better. Yeah, Adriana, or she was going to be on. She told specifically she's going to come online. I was going to invite her, but she's not on here. So.
Maybe she'll just watch it later.
Well, yeah, and then like her husband, I know she spends a lot of time with her family, which is totally cool. It's like whatever, you shouldn't have to neglect your family to do this. And she knows her stuff. Like she's not
good.
struggling at all. So I'm like, yeah, whatever. And then Harmony said she would just be here. I don't know where she's at.
Did she
This is
come
not
yesterday?
your nerve
No,
wracking when I can't,
she
like,
came
fix
yesterday.
it right away. Okay, so just do this. So from the top or from the bottom? So from the top or from the booty? And then we have so the overt. I should probably draw this while we continue talking, and then I'll just like go over it. If you guys
So
want
irritable bowel.
Okay.
Irritable bowel. Let's go over to irritable bowel. And we kind of, in our review questions, the Jeopardy, we kind of already went over this. So irritable bowel is what? What was the big thing for irritable bowel?
It has a site component, and there's no damage.
Site component, and it recurs. It keeps coming back over time.
Yeah.
It just keeps coming back, and it's
3 times a month.
3 times a month. Yeah, you get 3 times a month. It keeps coming back, and you're gonna get yeah. Okay, that's irritable bowel. Okay, site component. Okay, so here are the signs and symptoms. So it's at least 3 times a month for 3 months consistently, with or without injury. So it's going to be with or without. It's going to be without something else causing it. So if someone gets punched to their stomach and they're getting irritable bowel, there's a trauma. Right? They got hit. Like there's a reason for it. Or they got an infection. There's a reason for it. But a normally healthy person comes in and they keep having irritable bowel, then that's why it's irritable bowel. Okay. Dietary management is being focused on FODMAP, foods that seem to cause hyperstimulation of the intestines. So see the videos. General diet recommendations are eat smaller portions more frequently, reduce fat content, and avoid dairy, alcohol, caffeine, and avoid gas-producing foods, so high acid and stuff. Stress management, medications, laxatives, or antidiarrheal medicines, and antidepressants as prescribed. And that's irritable bowel. Okay, so now we're to inflammatory bowel disease, or IBD, which is the 2 Crohn's and ulcerative colitis. So the big ones for these ones are what? The big overriding shell on these is what?
They're both autoimmune.
They're both autoimmune based, right? Okay, so let's look at the difference between the 2 of them. Okay, so Crohn's. So Crohn's has familial tendencies. It peaks with age from ages 15 to 40. It's autoimmune. It's based nausea and vomiting, severe diarrhea, low-grade fever, bloody stools, which is like steatorrhea, and then weight loss, and then severe malabsorptions. They don't absorb nutrients very well.
Okay.
Late signs and symptoms are dehydration, electrolyte imbalances, and anemia. And then complications are intra-abdominal.
Sorry, can we borrow 2 of these chairs?
Yeah, go ahead. We're not using them.
Okay.
You came walking by, and I was like, "We got a reservation till 8." It's being too damn loud. Intra-abdominal something. Can you read that? I can't read that. Mine. Intra-abdominal something.
Abscesses.
Okay, that's just like, yeah, that's like little. Yeah, an abscess is like,
Fistulas.
yeah.
Or peritoneum.
Yep, and then develops what? Fistulas.
Fistulas.
Yeah. And those are like little nodules.
Like skin tag.
Yeah. Okay, ulcerative colitis is yours.
Okay, so it's only in the large intestine,
Yep.
right?
So Crohn's disease appears where?
Oh.
It appears all through the GI system, where ulcerative colitis is just in large intestine.
Ulcerations only occur in the colon, blah blah blah. Involve the mucosal layer
So yeah, what's the mucosal layer?
of the.
So how many layers are there in like a vessel in the body? On any vessel, blood vessel, intestine, anything like lymphatic tissue. How many layers are there usually?
Like 3.
There's usually 3. There's like a layer closest to the lumen, an inner layer, and then an outer layer, and those can be subdivided more, right? But there's usually 3 main ones. So the mucosal layer is what layer?
Metal.
It's the one closest to the lumen because it's mucus producing. It's called mucosal for a reason. It's where the mucus is produced.
Okay.
Look at the complications in this guy. Intestinal obstruction, dehydration, fluid electrolyte imbalances, malabsorption again. Look at this one, iron deficiency with anemia. So they're not iron, so they're not digesting iron, so they're going to be low iron in their blood. Chronic bloody diarrhea mixed with mucus, weight loss, abdominal cramping and pain, nausea and vomiting, and the urge to defecate. That sounds like fun. Acute complications, hemorrhagic or toxic megacolon. Oh, the most severe case of UC can cause damage to the nerve plexus, resulting in colonic dysmobility, dilation, and eventual infarction and gangrene, a condition termed toxic megacolon. Gangrene is like really bad. And then it's high risk for rectal cancer. How exciting is that? Yeah. So what are the functions? Okay, so that's those two. Let's just go through this really quick. Ask in the next block. So ulcerative colitis, its family history is not a factor. Location of lesions is large intestines only with no skip lesions and affects only that inner mucosal layer.
Okay.
Anal, perianal fistulas are rare. Bloody stool is common, and treatment, steroids and MAP drugs, possible surgery, and you just take Crohn's.
Okay, so the family history is frequently associated. Location, lesions in large and small bowel. Skip lesions are common. It affects the entire bowel wall thickness. They're common, may require colostomy. Bloody stools are uncommon. Treatment, steroids and MAB drugs also. Surgery to remove portions of a non-functioning colon is common.
You guys know what a colostomy is, right?
Like a colostomy bag?
Yeah, like a colostomy bag is one of the things, but it's just what they actually take a piece of the colon away. It's like my dad just had one. They took a piece of his sigmoid colon out because it got blocked, and the tissue around there, because it got blocked, it wasn't perfusing well, and they had this big blockage of stool in there. So they just removed the whole piece of it. They removed, and then they joined the two pieces of colon together. And that's for him. He doesn't have Crohn's or ulcerative colitis, but that's what they end up doing in his case for that.
Yeah.
Because the tissue around that blockage dies. So they cut it out and they join it together.
So this might sound stupid, but what causes them, like ulcerative colitis?
Well, these are autoimmune disease.
Okay.
They're
so
autoimmune
it's just
based.
like-
That's it, autoimmune based. So Yeah, it's like diabetes, right? What's
Yeah.
diabetes caused by? Well, it's an autoimmune disease. In type 1 is autoimmune.
Yeah.
In type 2, there are some risk factors like being obese,
Diet.
diet, not working out and stuff. Okay, you ready to go on your thing?
Yes.
Let's do it. Show us your thing.
So, sorry, I didn't like the way that she had it here,
No, you're fine. Just
because I couldn't categorize it in my head.
anything you show us is gonna stick tomorrow. So
So the occult GI bleed, I like.
it's a silent killer. Yeah.
I like ridiculous because it makes me remember it. So like this dude is like looking at this poo through this like giant,
Ginormous
telescope.
microscope or telescope.
And I will remember that. So the test that you need is the hemoccult test, and that's the giant microscope, and he sees blood. So that's what the occult GI bleed. That's the only scenario. Is basically you can't see the blood unless you do a test.
I just remember this one's a poop smear. You poop smear it and you put the chemical on it and it goes to blue if it's got blood there.
And then the overt GI bleeds are gonna wait. I put this in the wrong category then. Sorry. Okay. So the overt GI bleeds are gonna be these two on the bottom, but melena is black and hematochezia is red. Sorry, for me it just helps color coordinate.
Oh, okay.
And then this isn't the GI. It's not the GI, is it?
Hemoptysis is vomiting, so it's upper GI.
But it is GI, right?
Yeah, it's GI. It's
Okay.
GI.
So I didn't do that wrong then. So the overt GI bleeds. So these are all of them that you can see. So the only situation.
So your little guy, this would be upper and lower. That's, you got that correct. This would be, you put upper and lower, and then it would be upper GI bleed, lower GI bleed, and then it would be totally perfect.
Okay. So it's like from the top, you have hematemesis.
Yeah, hemoptysis. Yep.
Hemoptysis.
Yeah.
And then there's only two, and basically they just describe. So you only see hemoptysis in two versions. Either it's bright red or it looks like coffee grounds. This is supposed to be a coffee ground. And then I just color coordinated them. I don't know if that's helpful to you guys, but I always like looking at
And then which one's more dangerous on each side? On the upper GI bleed or the top? Which one's the one that we're most concerned about?
Bright red.
Bright red and why?
Closer to the airway.
Okay, and then on the bottom, which one are we most concerned about?
the black.
The black, why?
Because it's further into the system, and bright red would usually means it's right next. It's just like hemorrhage. Or something.
Yeah, it's right next to it's right next to the anal opening, and that's not, who cares? Like, I mean, we care.
It hasn't been digested.
Yeah. Either side, it hasn't been digested. Good job. No, that's great. See, your little pictures are so cool. Sorry, they're just awesome. Okay, colorectal cancer. Yay. Colorectal
What was that
cancer.
test called again?
Hemoccult.
Hemoccult, that's right. Which occult means hidden blood, right? And it's hemo, so it's looking for hidden blood. By definition, that's what it means.
Yeah.
Which is kind of cool, right? And I just remember as a poop smear.
But the good thing is that like basically the test question is going to be set up some kind of way that like you have a person that comes in with hematemesis. Hemoptysis.
Hemoptysis. Yeah. Those girls are going crazy, man, over there. So there's hematemesis is bloody vomit. Hemoptysis is bloody sputum.
Yeah. So I'm not thinking hemoptysis. I mean hematemesis.
That's the bloody vomit.
Yeah. And she's probably going to tell you what color it is, and then you have to figure out what the problem is, right?
Yeah.
Okay.
So if you got like upper GI bleed and it's bright red,
She's not going to tell you it's upper GI bleed. She's just going to tell you what the patient is experiencing and what you can see.
so yeah, it's bright red bloody, it's vomit. Hemoptysis. Okay,
It's coffee grounds. It means that
it's in the stomach and it's partially
It's
digested.
been partially digested. If it's black poo, that means it's been partially digested
digested.
in the bottom. If it's bright red, it just means it's probably hemorrhoids or something like that.
And I never named my kid Melina. If I ever have a daughter, she's never going to be named Melina because of this class. I want my daughter to be dark red, crappy, bloody, stinky poo. Okay, guys, colorectal cancer. How exciting is this? Okay, this guy affects both men and women, but it affects men more. Okay, 1 in 20 people with this will be diagnosed with 1 in 20 people will be diagnosed with colon cancer. A third will die. So this is like what the second leading cause of cancer death in the United States.
And it's really treatable if caught. If caught early, the only problem is it has no signs and symptoms.
Yeah,
so
it's like
extremely
lung
deadly.
cancer. We don't know about it until it moves somewhere else, and then we detect it because we do a biopsy and we do the cell culture, and this is colorectal cancer. It's up in the lung, or it's over in their back, or it's up in their brain somewhere, or it's in the heart, or whatever. We find it somewhere else, then we realize it's something else, and then it's metastasized, which is the worst. Okay, 50-year-old men are the biggest people to get it. Races, what races get it?
Black and Caucasian.
Yep, black and Caucasian, or a good picture would be yin and yang, black and white would be getting it. Family history, 25% have already had colon cancer, and the family history has a predisposing condition. Medical history, Crohn's or ulcerative colitis are big indicators of this. And obviously there's an autoimmune component too there, which may be helping the cancer to survive.
Well, it's just, it's because you have the dead areas in the intestine.
Yeah, you have your skip ulcers and the fistulas and all that stuff in there, and the cancer can grow in there. Because of ulcerative colitis and Crohn's.
Yeah, it's just, it's because there's a lot of damage. Like, you have a lot of inflammation going on. You have a lot of damage to that area. And it's just like, I think it also, the way she made it sound in class is that it's also really common just because you can develop toxic megacolon, and then that develops into colorectal cancer.
Yeah, toxic megacolon just is nasty. That doesn't sound good at all. I don't ever want to get that. Yeah, there's those times I need to put me out of my misery.
And then that one's like the #1 complication.
What, toxic megacolon?
For ulcerative colitis.
Colitis. Is colon cancer or toxic megacolon?
Toxic megacolon.
Is the #1 for ulcerative colitis, and then that leads to colorectal cancer.
Yeah.
Okay, American diet, obesity, lack of exercise, smoking, alcohol, those are like standard. And then rectal cancer is increasing rapidly in the 40 to 50-year-old range. That's me, I'm scared. The National Institute of Health study found most patients diagnosed with colon and rectal cancer under the age of 50 experience signs and symptoms, have left colon and rectal cancers, and are diagnosed with more advanced diseases. That's just freaking sad. Okay, who wants to cover the pathology of this? Because it starts talking about polyp types, and I'm still kind of a little bit not up to speed on those. So yeah, so it says most colon colorectal cancer. Do you have a picture for this? Begin as a growth called a polyp on the inner lining of the colon or rectum. So those are like little bulbs, little nodules that come out.
Sissy space?
Yeah, those little nodules. Yeah, that's a class, obviously 0, 1, 2, 3, 4, and those are the stages of just normal cancer. Every cancer has those stages. So that's not new. We should kind of remember that. And then obviously what they're intruding into. Okay, so and then the polyps can change into cancer over the course of several years, but not all polyps become cancerous. The chance of changing into a cancer depends on the kind of polyp. And then it talks about these two kinds of polyps. So adenomatous polyps or adenomas. These polyps sometimes change to cancer, but because this adenoma is called precancer, because they are called precancerous adenomas or precancerous condition. And then these every time I hear this hyperplastic, that's the one that always reminds, like when I hear hyper, it reminds me of a metastasis, right? It divides quickly. So every time I hear hyper, it makes me think that's the one that's the.
So essentially.
But it says this one is not precancerous.
So essentially these are metaplasia.
Yeah, it's change of tissue to something else. So,
that will withstand the stress better.
Yeah.
And it eventually, if it keeps doing that, it's going to eventually turn into cancer.
Yes. And then adenomatous polyps are the cancerous ones. They're considered precancerous, but hyperplastic polyps and inflammatory polyps are not considered precancerous. I mean, clearly they could probably develop into cancer because all of them can, but those are the ones that are less aggressive. And that's what always throws me off, is this one's always like a little bit reversed for me. I was having a really hard time with this. Signs and symptoms, there usually aren't any. So you have to screen for it. So again, for men, I'm probably going to be getting ready for the silver Cadillac here pretty soon to check for this. What was that?
What's the silver Cadillac?
Well, it's where they stick a probe up your butt, and they call it. It's usually cold, so they call it silver Cadillac. So when the doctor does a rectal exam, they stick their fingers in there and feel. The next stage for them to stick a scope up in there, and they call it the silver Cadillac.
Every single time I read this page, I literally just start harassing my poor husband and dad and just be like, "Go get your
Go get your colorectal
like immediately,
screening.
I'm like, have you gotten it yet? And they're like, no. And then I'm like, do it.
It's a silver. Just say the silver
But I'm
Cadillac.
it's literally every time I read this page. I feel I'm reading this page right now, and I'm gonna sit there and text them.
So if it's found early, we can cure it. Okay.
Because that's sad that it's completely treatable. It's just that you can't tell you have it.
Well, it's
just
okay.
every year if you just go to get checked for it, you could live through it.
How many ladies right now are not doing breast exams? Physically checking their. if you look at the statistics, a lot of women aren't doing it.
So I don't know how maybe you feel about it, but I'm I personally you have you have sometimes texture. And then you go in and check, and then they're like, no, it's not cancerous.
Mm-hmm.
So then, you sit there and you just wasted $100 going to the doctor. So they can tell you, oh, it's not cancer. And then they don't exactly tell you what to, what they just anything that's any kind of texture, you're supposed to come in. So you're sitting there spending $100 every couple months because you feel something new. And that's kind of been my experience, but I'm also a thicker woman. So it's it might just be that I'm because I have little.
Well, we
fat deposits.
we learned in our cancer discussion though, we learned that more aggressive metastasized cancers, they won't move.
Mm-hmm.
Where other growths or other they'll move, they'll shift.
But I learned that in this class.
Yeah,
I did
that's
before.
Your doctor
I used to
should be telling you that.
but before I used to I've been doing my screening since I was 18.
Yeah,
but I'm but the thing is that I had to go into a pathophysiology class, which you have to take 3 other precursor classes
to get to that.
To get to oh, that's what I'm looking for.
No, I'm saying this.
You know how irritating that is as a woman that I've been to several doctors, and then they're like, oh no, but oh, you'll take my $100 for me to make this appointment. And I'm like, I don't even have the money to be going to the doctor that often, but I'm I would rather pay the $100 now if it was cancer and get it removed than find out later on that,
it wasn't. It's just garbage. No, well, I'm just saying I'm saying for me as a caregiver, that's one of the big things I'm going to tell people. Yeah. Hey man, some girl comes in, hey, I got something happening. Does it move when you move it? Does it move or does it stay in place and hold? Does it resist?
Well, another thing is, and I think this is probably the thing that the last doctor that I spoke to told me is that if it feels like a grape, it's fine, but if it feels like a raisin, then it's bad.
Why would that be the case? We know from our cancer lecture why that is. Because non-metastasizing, differentiated or non-differentiated cells get that capsule around them. It holds them together in a round ball, and it gives them a smooth covering, which is kind of cool. Sorry,
no, but that's what
I don't know why.
But that's what I'm saying. It's just
cancer, I'm sorry.
No, but you were saying that how many women don't do it. It's just but it is a really frustrating situation. When I think everybody's different, and I know that my particular case is weird just because it's I think that when you're thicker, you probably have because you have the things that they were talking about on the screen. It's nobody else can tell, but you can when you're doing your checks, you can tell.
Yeah.
Type of things. I don't know. I'm just okay.
No, you're okay.
I'm not trying to make anybody uncomfortable.
I opened that can of worms.
I just wanted to say that it's just, I think it's much more difficult than just checking every couple months. I think it's much more difficult than that because then first of all you're worried and then you have to make an appointment and then all of that and then it turns out to be nothing and then you just feel like you're wasting your time.
And there's a reason that guys die a heart attack more than women because they're number one. The people that you say, oh, don't wait to get seen if you're having chest pain, because what every guy assumes. He assumes it's. My old man hadn't taken a crap for 3 days. We had that blockage in his intestine, and I had to tell him, "You're going to the hospital." You know what I mean? Because he just wouldn't. He's trying to talk himself out of it. He's like, "I should have a bowel movement." Well, if you're not having a bowel movement 3 days, and you normally have one a day, you're going to go to the hospital because that's not normal, right? And so then he went, and sure enough, he has this huge block.
Or the least you can do is at least go to urgent care. Even if you don't go to the emergency
ER, yeah.
Go to urgent care and just see if maybe it's something that you should go to emergency room for.
No, you're good. I'm with you. Okay, signs and symptoms. We got some of that. Changes in bowel movement, constipation, diarrhea. They don't go away. Feeling you can't empty your bowel completely. That doesn't sound like very much fun. Or urgent need to move your bowel. Rectal bleeding or cramping, dark patches of blood in the stool, or long, thin pencil stools. That does not sound fun either. Okay, abdominal discomfort and
Let's
bloating.
stop talking about poo.
Unexplained fatigue, loss of appetite. We got 3 more pages before we start talking about poo.
No, we have a hepatic
Yeah.
liver.
Yeah, liver stuff's next, but that's gonna drain into poo. Unexplained fatigue, loss of appetite, weight loss, pelvic pain, which can happen in later stages of the disease. Okay, we do an occult blood test on this, so stool smear or poo smear is what I like to call it. Colonoscopy, we physically have a look. That's the silver Cadillac, and then they locate any tumors or anything, biopsy, and then they remove the polyps at the same time. That's how they treat it. Okay, you should start beginning screens at least at age sooner at 50, but sooner if you have a family history for it. And then new treatment standard in the United States, preventive service task force recommend taking a low dose aspirin to prevent colorectal
She
cancer.
said in class that the is now 45.
Okay.
But I don't know if that's for testing purposes or if that's just to let us know that it's now 45 when we go into our careers. Because it's getting younger.
Everything's getting younger because people aren't taking care of themselves. Okay, hepatic pathologies. There's 3 of them. What are they?
Pre-hepatic, intrahepatic, and post.
Same as the kidneys, right? Okay, what's the mnemonic?
People drink so much.
Okay, so produce ABC, albumin, bile, and coagulation factors. Okay, detox, especially ethyl alcohol, storage, glycogen storage, and then metabolism of protein. You break down proteins. Send that crap off. Okay, and then obviously ammonia and nitrogen are the byproducts of that.
So just something I noticed from class.
How do you remember all this from class?
Because
You have a
I'm drawing.
Okay, you have a good memory.
So I'm like, when
Yeah.
you're drawing and you're not actually trying to pay attention, you like for me, I pick up a lot more on the stories than I do on the actual.
Okay, I'm like, how do you remember all this? I can barely tell.
So like one thing that that became very apparent to me during class is they love bleeding problem questions. They love to associate bleeding problem questions with liver diseases. So just
Okay.
something to look out for
No,
in the
you're good.
midterm. So it's like make sure, because half of the questions are going to be on the liver, on a section that includes the liver, make sure to know all of the platelet counts
Yeah, 150 to 400.
and the coagulation factors. Like
Yeah.
anything associated with that.
Yep, if there's low coagulation factors.
Because I honestly, like during the class, I heard like 5 different questions. And they were just kind of like, what would happen if this? And what would happen if that? And I just kept thinking like, wow, there's a lot of bleeding problem questions when we could be talking about other stuff. So they must really like those questions.
Yeah. Yep, it just says right here, recall from the hematologic system unit that the associated organs for platelets is the liver.
Yeah.
It's noted right there. Okay, ethyl alcohol and drugs, glycogen storage. It's stored in the liver for release when the body needs it. That's when you need a rapid sugar hit, and that's going to be fight or flight. It's going to be a fight or flight response. Okay, metabolism of protein. Protein digests in the small intestine, produces ammonia, and the liver breaks that down and makes it into urea and sends it to the kidneys to be removed, to be excreted or traded out.
Flow chart for glycogen.
Show it, man. Show us your flow chart. You're going to have to publish that and make money. Dude, look at how well you draw. Jeez, okay. Every time I look at a little book, I want to steal it.
I know.
Okay.
Make copies of it.
I actually have 2 different types of flow charts for glycogen. So I have this one that has like the insulin. This one was really cool from physiology.
It's like physiology. This is physiology. This isn't patho. This is the correct flow.
So
Plus B cells plus insulin, permissive.
we're not going to get that close into it.
Yeah, they didn't talk
So
about
it's
it.
just like this one is so just like following the system. So it's like, let's say that you just ate lunch. So it's going to go through glycolysis. Now let's say that you didn't, like it's been an hour or 2 since lunch.
So you still need sugar.
I remember what it was. Okay, so you just eat lunch and you have so much glucose in your system that your body
So if you have too much, it's going to convert some of it into glycogen and then use whatever it needs. Now, let's say it's been an hour and now you're hungry. Your body, in order to keep your brain running and everything, it has too little in the system, is going to convert it back to glucose and still maintain the glycolysis. See? It's glycolysis, right? Yeah.
Yeah.
And then if you're exercising and you've used up all your glucose that's readily available and all your glycogen that's readily available, then it's going to become fermentation, and that's the reason why you build up that's when you don't have oxygen.
Yeah, fermentation is because there's no oxygen present.
Yeah, sorry. When there's no oxygen present. Now, let's say that you have used up all your, let's say you're in starvation mode. It's been a while, and let's say you're on a crazy diet and you're not allowed to eat any glucose. Your body is going to then transform lipids, and it's going to.
It's going to break the lipids down using that.
It's going to do lipolysis.
Yep, lipolysis.
And then after that, it's going to do proteins. If those two, or if none of these are available, if you're in starvation mode, then it's going to go glyconeogenesis, which means the liver.
It's going to start breaking down muscle tissue to get the energy it needs.
Yes. I wish I could remember exactly what it was. I bet if I redrew it, I would remember, but I'm not going to do that. Sorry to waste your time.
Oh, we're not wasting our time.
But I just, let's continue. Sorry. I had something and then I forgot what it was halfway through.
Yeah, that's liver stuff, what liver does. So some people drink too much. So some is ABC, albumin, protein, and metabolism. And then drink detoxes, storage of glycogen, and metabolism of protein. Okay, let's move on. Cirrhosis. What's cirrhosis?
Inflammation of the liver.
Yep, scarring of the liver tissue, and that's obviously because of inflammation or elevated and unresponsive inflammation. Okay, it's most commonly caused by what?
Drinking.
Yep, drinking alcohol is the biggest thing that happens. So people stop doing that, they don't get cirrhosis, but they don't stop doing it, okay? If it's oxidized by the liver, acetaldehyde, which damages hepatocytes. And hepatocytes are just the small filtering cells within the liver. That does all the filtering and splitting the stuff out of the hepatic portal vein, breaking it all apart and getting the good blood back to the heart and breaking all the nasty stuff and sending it to the kidney to piss it out. Okay? Or the pooper, depending on what it is. Cirrhosis can also be caused by what? Viral hepatitis. And then obviously hepatotoxic drugs. I'm not even sure which hepatotoxic drugs they're talking about. Okay, so the scar tissue prevents the normal flow of blood through the liver. It causes a backup or portal hypertension. It causes that backflow and slow down of the blood through the hepatic portal system. So if it's causing backflow in the hepatic portal system, what are the other organs that are that's coming from? What feeds into the hepatic portal system? There's three organs, the main organs that lead into that feed into it. The mesenteric arteries and veins feed and take blood from what? Anatomy review.
Intestines?
The intestines, large and small intestines feed into the hepatic portal system, and the spleen. The spleen flows back, and that's why you get that megasplenic stuff. The spleno
So the
inflammation.
hepatotoxic drugs are basically drugs that don't hook on to any kind of protein. So the liver immediately recognizes them as not its own and is trying to take them out of circulation.
Pull them out.
So it's just basically like the spleen where it starts to get there's too much stuff.
Other crap that it can't deal with.
Yeah.
Okay.
So that's the reason why, for example, the antifungal medication for nails and stuff like that.
Oh, okay.
That one, for example, you can't drink and take that, and the reason is because if you were to do both of those, your liver would be trying to detoxify too much, and then it would just
the nail polish remover. I think isn't it butane? butane base, I thought.
No, there's a, like, ingestible. Like, not one that you put on top.
Okay.
Sorry.
No, you're okay. So when the liver gets damaged, it causes the protein breakdown to slow down, which means you don't have protein in your blood. You don't have protein in your blood. We have plasma proteins in our blood that are larger molecules that draw water to them. When they're removed, it causes that water to not be pulled back into the blood system. So when that blood isn't there, when that water isn't there, what does it do to the blood pressure? It's going to be lower. When those plasma proteins aren't present, it's going to be hypotension is going to be one of the issues. And it says here leading to ascites. Okay, ascites. Okay, so fluid backflow causes portal hypertension, esophageal varices, hemorrhoids, splenomegaly. The stuff it's talking about. And then protein loss, decrease of protein in the capillaries, no pulling action, draws the fluid, ascites, and congestion.
How does that cause ascites again?
Well, because plasma, so there's constituents in the plasma, right? There's red blood cells, or sorry, in the blood, red blood cells, white blood cells, platelets, right? Then we have a whole host of plasma, okay? They're called plasma proteins because they're fixated in that plasma portion of the blood. If you don't get plasma, if you don't get protein and breakdown to get proteins from the liver, they stop working. Those plasma proteins are no longer present in the plasma portion of your blood. And those things, because they're larger molecules than water molecules, they're larger structures, by gravity, larger molecules pull water to them, because if those aren't present, then they can't pull water from the tissues back into the blood.
But ascites is different from, this is why I'm curious, because I understand, I guess I understand why, but how does it end up being like free fluid versus just fluid in the tissue?
Well, what happens is, so when the plasma proteins aren't present, I did a thing for this yesterday, or not yesterday, somebody would.
I'm sorry.
No, you're okay. So here's your blood, right? Okay, so there's two things I have to draw. So here's a blood vessel, right? You got red blood cells, white blood cells, and you got little platelets, right, floating through there. Well, in addition, you have all the plasma. Remember our test tube?
Yeah.
This is, you'd like to see things, this is gonna help you. So this middle line was white blood cells. This stuff down here is red blood cells, and hematocrit and all that. White blood cells. And up here, this is actually plasma. Plasma has platelets in it. Yeah.
Yes.
Platelets in it, but that's only a small component of this. There's other stuff in this. Electrolytes live in this. Okay? Plasma proteins live in this. Okay? All these structures are larger than water. They're all larger than H2O. We know that there are two processes. There's a chemical process, the osmotic pressure, or osmotic forces, where it's positive and negatives pulling it. It's also, I call it the gravity principle. Jupiter is bigger than Earth. Therefore, it has larger gravity. The sun is the largest structure in the solar system, so everything revolves around it. So anything smaller than something else is going to gravitate to it. So platelets are larger than plasma protein and electrolytes. So these guys want to gravitate around them because platelets are larger. White blood cells are the largest component of our blood, and so other things want to congregate around them because their mass draws things to them. So because plasma proteins, so say that 40% of this was plasma proteins. That means 40% of just the gravitational pressure to keep water to it, that's 40% of it. What if I reduce the amount of plasma proteins to 20% now? I've reduced the amount of plasma proteins that are present. So therefore, 20% of my force to bring water to me is now no longer there. So they're saying if the liver, which breaks down food to get protein, if the liver is damaged due to like cirrhosis, if cirrhosis is causing those hepatocytes not to work in the liver to do this process, it's saying that plasma proteins are no longer present in the blood, and so it's allowing the blood pressure to drop, as well as the gravitational forces, and that's what causes ascites and edema in the body to happen because of this.
But it's not edema.
Well, it's not. Ascites is that it's leaving the blood vessels and it's pooling in the first open space that it can find.
It's just, the only difference is that it's just it's kind of like a hemorrhage, but instead of actually being blood, it's just like the plasma.
It's just water and stuff that's leaking out because there's nothing. It's not big enough.
Because the liver is kind of a filtration system. So
Yep.
instead of actually getting blood in the liver, you end up with just a really odd liquid.
So we still have like that epithelial layer around the blood, right? Around the blood vessel.
Yeah.
So what we're saying is plasma proteins are gone,
Mhm.
but there's only that's only one component of the blood. These openings, these tight junctions between the cells are still intact. So can platelets leave?
No.
Can red blood cells leave?
No.
No, white blood cells can't leave. So only structures that are plasma protein and smaller can squeeze out.
So it just essentially like it would be edema, but then there's a cavity for it to collect in. So it leaves the tissue because there's a cavity.
And yeah, there's just an opening is a place that has less pressure. And so it's just like, hey, this is a place we can stop. So the blood pressure is lower.
Oh,
So if the
okay.
blood pressure was kept up, say the blood pressure, say we infused fluid and broke the blood pressure up, this couldn't happen even with the plasma proteins gone because the speed of this blood is too high.
Mhm.
It'd be traveling too fast to get to where, but hey, if the normal freeway speed in here, so I use this freeway, these are cars now, there's a semi, there's an SUV, there's a little shitty Toyota or motorcycle or something, and these guys are going at 50 miles an hour, right? MPH, they're going at 50 miles an hour. At 50 miles an hour, nothing, including water and electrolytes and plasma proteins can just leak out. But what happens if I lower the blood pressure to 30 miles per hour? Well, now these little crappy guys, they can hit that single lane freeway exit. But these bigger guys can't, they're still going too fast to pull off the freeway to get off the road. So that speed is what's helping to control those things leaking out. So with the lower blood pressure and with the plasma proteins being gone, it's allowing everything else to just leak out. It's allowing to leak, and that's where ascites happen. It's just that massive cavity, and it's big enough that it can leak out in there. Okay, are we?
Yes, you answered my question.
No, I just want to make sure we're all different.
And so much more.
Okay, so yeah, that's what's going on. Okay. Woo! Yeah.
Sorry about that. I was having a really hard time
that's why
like
we're
figuring
here.
out why it wasn't just
So
like
it's a
edema.
relationship. It's a relationship. So we just beat the crap out of the electrochemical part of it, right? The positives and negatives and electrolytes and all that stuff. But we spent a very little time talking about the size of an object, that everything smaller than it wants to gravitate around it. And that's also some of the forces that are holding the blood components together. So using a good example, when there's an active hemorrhage, right? Okay, remember there are like so there's an active hemorrhage now. There's an opening, a straight up opening, but it's this big. Red blood cell, white blood cell, platelets, right?
Then you actually are getting blood.
Then you're getting flow. So I've actually got flow. But what happens is the smallest components get the most force to be pulled there. It takes quite a bit more force to move Jupiter out of its orbit than it would be to move an asteroid out of its orbit. So think of this as an asteroid. So the first components to be pulled out are going to be H2O is the smallest thing in there. So H2O is going to get pulled out first. As H2O gets pulled out, it's going to want to pull the next largest thing with it, which are plasma proteins. Now the plasma proteins are coming out. When the plasma proteins start to move, platelets are going to start to move. Platelets start hitting there, and then those clotting agents are coming with it. Those guys start hitting this, and that's when those clots start to form. Now, red blood cells and white blood cells can't always leak out through an active hemorrhage, but this is the other part of clotting that we didn't spend as much time about. We talked about, hey, platelets hit, and then those clotting factors hit, and it causes them to expand and get little feet and cleats, and then it stops, and it builds this clot, okay? So again, that's the other part of this that we haven't talked a lot about, that this gravity of an object also determines, again, it's like when you're sitting in the tub and you pull the cork out, your body doesn't move to the hole that the water's draining out of, but your little rubber duck does, because it's not as big as you. The smaller objects in the tub and the water get pulled to the tub sink, right, quicker, right? So a little person like Rose in the Titanic, her and Jack sank with the boat because the boat was the largest thing. But when the boat finally went under, it sucked everything with it down because now you got the largest structure in the water going down, and it's pulling everything smaller than it with it. So it's the last thing to sink, and then when it sinks, it pulls everything with it. And that's the same with our blood, just because of size. which is, that's physics. I'm sorry. I got excited. I got a little too
I
excited.
like the Titanic comparison.
So yeah.
I like
So-
the rubber ducky.
So, yeah, so
I
here's
did
your,
like the
here's your
herd.
tub. Here's your tub. Here's your cork. Here's you.
Well, I don't need a picture of it. I pictured it on my own.
Here's Titanic, and here's your rubber ducky over here. When I
See, that's the problem with these pictures is that a lot of them are like in here,
Yeah.
and this is only what like.
Yeah.
This is like notes of what's in here.
So when you pull the cork, which object wants to move to the hole first? You, the Titanic, or the duck? The duck wants to go first. It's smallest. Okay, I'm done. We beat that to death. Let's move on.
Sorry.
We got 10 minutes. We got to be out of here. So, and I had to kick some Chinese guys out earlier, so I don't want to be getting kicked out. Okay.
You don't want to anger anybody.
Well, I just want to be a good neighbor and stuff. Okay, so portal hypertension, obstructed flow. So that would be, what's portal hypertension? Would that be pre, intrinsic, or post?
Pre.
It'd be pre. It'd be considered pre-hepatic. Okay, splenomegalia is just an enlarged spleen. So backup of fluid in the portal vein and organ engorgement. So those organs are going to get engorged and inflamed. That's the intestines and the things that are downstream of the hepatic portal vein. Esophageal stomach varices, splenomegalia, ascites, and hemorrhoids. Yay! How awesome is that? Okay, ascites. What's ascites?
The
fluid.
Yeah, it's fluid building up in the bottom of the abdominal cavity, and it's caused by two problems. Portal hypertension increases it, and damage to the liver, which doesn't allow those proteins to be put in the blood, causes it as well because there's less stuff in there to hold water to it. Hepatic encephalopathy. Without even looking at it, what is this? What's going on with this? Encephalopathy is brain stuff, right? So it's hepatic stuff dealing with the brain, and if it's dealing with the brain, it's dealing with ammonia because ammonia is brain poison. So if the liver's not doing its job well, it's allowing nitrogen to form into ammonia, and it's not sending it to the kidneys as urea. It's not forming urea with that ammonia, and so that ammonia is allowed to get back into the blood, and where does it go? It goes to the brain, and it causes us to have disrupted mental status or change in LC.
And then this one is one that causes the dripping in.
Yeah, so that's
Asterisk.
asterisk factoid. Yeah. So that's
they had similar names for some of these.
flapping hands. Then jaundice. What's going on with jaundice? Somebody else tell me what's going on with jaundice.
The yellow skin.
It's and they call it icterus, right? Yellow or orange sclera, eyes, skin, dark urine, Coke syrup, which that's the color of the urine, which that's nasty. I've seen it once. Light colored stool. Why is it light colored stool and not dark colored stool? Why is it light colored?
I don't know.
Because the dark colored bilirubin is in the fecal matter, but if your liver stops working, it's not making bilirubin. It's not getting into your stool. So you're gonna have a light gray, white looking stool because bilirubin is missing from it. It's not physically present to give it that color.
So the bilirubin is the one that gives it the color.
The brown color, yeah.
So if it's too dark, is it because there's too?
If it's too dark, what else could be causing the feces to get dark?
Well, that could be like the bloody.
Yeah, blood could be present,
Yeah.
right?
Okay.
So bilirubin is going to have a level, right? You're going to have and I hate to say this, I don't like talking about poop necessarily, but everybody in this room has poop that they looks normal for them, right? So when you look in there and you see it darker than normal, you know it's darker than normal. If you look in there and it's lighter than normal for you, you know there's a range that you're comfortable with. That's why people freak out when they see blood in the water with the stool.
Yeah.
It's just hemorrhoids, but they're freaking out because they're seeing blood they don't normally see.
Yeah.
So that's the same with this. So you have a range. So technically you could get too much bilirubin in the stool,
Okay.
but that's not a disease process we've necessarily studied yet. Well, maybe later on we'll learn something about elevated bilirubin in the system. And then hepatorenal syndrome. So just by its name, what's going on?
Low circulation, low renal perfusion, and that triggers the RAS system,
Yep.
which increases blood pressure
Mhm.
and vasoconstriction, kidney damage, and then less urine being removed. And then because there's less urine being removed, nitrogen waste products build up in the bloodstream, and that causes acidomia.
Yeah, azotemia, yep. But
The
there were
liver
two there,
can't
azotemia and uremia. What's the difference between those two words?
The azotemia doesn't.
It's elevated bun, elevated
Yeah.
creatine. You still have that present, but what's not happening yet?
No signs or.
There's no systematic signs or symptoms, so no other organ systems are being affected. So the rest of the body is compensating for hepatic renal syndrome. When does it become a problem?
The liver can't process the aldosterone.
Yep, it becomes a problem when we start seeing the kidneys and the lungs and the central nervous system responding to those elevated urea, the elevated ammonia and stuff in the system. Then we start to have a problem because now it's so severe the body can't compensate for that. Okay, hold on. Let's go. Jaundice, hemolysis of red blood cells increases bilirubin levels. So that's one of the things with jaundice. So it's destroying red blood cells, which is causing what? Increases in bilirubin levels. Okay, obstruction of bile flow from the liver increases reabsorption, and then intrahepatic disease inhibits bilirubin conjunction and excretion. So it causes that bilirubin to get really, really thick. So that's what's going on in jaundice. So that's where that yellowing is coming from. That bilirubin is building up and it can't leave the liver. So it starts to spill out and go other places. And that gives our skin yellowing, which where should it really be going? It should be going down to the stool and be getting excreted, and it's not because it's nice and heavy and thick and it just doesn't want to move very well. That sounds really painful. Okay. Hepatorenal syndrome occurs in up to 40% of patients with liver failure. Prognosis is poor because renal failure is irreversible unless liver transplantation is performed. So if you get hepatic damage, the next system to be negatively affected severely is what? The renal system, because they play so well into each other because of the RAS system and because of renin and aldosterone. Because remember, it's
the liver is the one that
processes
the aldosterone. So it's the one that takes it out of circulation. So the renal system will produce aldosterone, no?
Well, yeah. So remember, it's renin gets released by the kidneys, right? And the liver secretes something, and it's angiotensinogen. The liver stops producing angiotensinogen, which shuts the RAS system off because RAS can't be converted to angiotensin 1. It can't be converted to be angiotensin. It can't be converted to 2, which means it can't become aldosterone, and it shuts off the aldosterone even hitting the liver because it's not present to hit.
And then you can't lower the blood pressure.
And you can't lower the blood pressure. Or sorry, you can't raise the blood pressure because the renin system raises the blood pressure. Okay, we're good? Let's keep moving on because we're running out of time. Pancreatitis, we already talked about hepatitis. Well, no, you didn't talk about hepatitis. We talked about hepatitis. Oh, you were here for hepatitis. You
I
answered
answered a question. I think I understand as much as I need to for that one.
So pancreatitis. What's going on in pancreatitis?
Okay. So an injury or obstruction causes autodigestion or formation of cysts.
So why would a blockage in the pancreas cause it to eat itself?
Because it's not able to let these enzymes out.
And those enzymes still want to go to work, right?
Yeah.
That's why it's eating itself. And that's one of the only places that we see that, right? The liver doesn't do that. The kidneys doesn't do that. But the pancreas does. And so that's one of the key things about pancreatitis. It gets worse over time. It's because it starts eating itself. And if it starts eating itself, then there's no insulin being produced, which can lead to what?
Well, it can cause two things.
Yeah.
It can cause autodigestion or formation of cysts.
Yeah. Well, both are bad.
Yeah.
The formation of cysts is just about as bad as autodigestion because now you got damaged tissue in there. It's not doing any work.
And it's caused by alcohol abuse and gallstones.
Yay, gallstones.
Pain is a sign and symptom.
Yep, this is definitely painful.
And then I drew poo.
Show us your Snicker bar there.
Float or foamy poo.
Okay.
Floating or foamy poo.
So why is it floating or foamy poo? What's going on now with the poo? What does the pancreas secrete?
Oh, it's because it has a lot of lipid in it.
It's a lipid digester, correct?
Yes.
So when that's not removed, you have lipids, and lipids
you're pooing fat.
Lipid-specific gravity is less than 1. So it will float on water. So it floats when it's the toilet.
And I'm sorry, it's dinner time.
You're right. We're almost done. We have to be out of here by 8 o'clock. So, okay.
So nothing by mouth. That's
Yep.
really important.
Paracentesis is the way that we treat
And
this.
hypertension and shock.
Yeah, paracentesis is how you treat this because it causes ascites. Okay. What are the tests? LFT, liver function. Okay, and we check for liver enzymes, ALT and AST. Okay, and then those increase when the tissue has been damaged, allowing the enzymes to escape into the blood. Those shouldn't normally be present, but they're present if it's damaged. CBC?
Oh, shoot.
CBC? What's CBC? Complete blood count, right? So we're looking for checking for red blood cell count and platelet count. Looking for those. Those are going to be altered if the liver's damaged, which makes sense because erythropoiesis is not going to be getting
I went
produced.
over pancreatitis instead of paracentesis.
Paracentesis is easy. It's just
The procedure.
it's just relieving the
Okay, sorry about
ascites. No,
that.
you're
Though. I
okay.
was totally on the wrong page.
Ammonia levels are monitored when the liver decreases its ability to break down proteins because we're going to have elevated ammonia when that stops happening. Okay, and that's going to cause encephalopathy. There it is. I said it right. Bilirubin levels do not make if liver does not make bile. Bilirubin levels, breakdown byproducts is not clear from the blood, so bilirubin will be present. It shouldn't normally be there. PTT, and INR are all they white blood cell, platelet, or red blood cell tests.
What do they mean?
I thought they were red blood cell tests. Where would that be at?
No, they're platelet tests.
Those platelet tests? I'm gonna write that down
They
right
test for
now.
bleeding problems.
Okay, I'm gonna write that down right now.
You do
Yes.
them when PTT is to test for heparin, and PT is to test
Hold
for
on.
communion.
Those are platelet
Communion.
tests. Those are platelet-based tests. And
What was-
PTT, what was it again?
PTT is heparin,
Heparin, okay.
and I believe INR is also.
Don't you have a picture in there for that?
I actually probably do. Sorry.
Because I missed a question on this. I could not remember this. And I had a note here to look it up, and I haven't looked it up yet. What's PT do?
PT test for commutin. That doesn't sound right at all. I'm sorry. I'm really
Okay, INR. We're feeding off the you, killer, because you know this stuff, and we don't know it right now. We're still learning this. That's why I'm glad we're doing a study group thing, because someone knows it. I don't know everything. I know some of this stuff, but I don't know it all. There's Dick.
There it is. I do have a picture. So, okay, so this is all like platelets. Like that's what you're testing for, and those are produced by the liver. That's
Yep.
why that's so important.
Okay. I thought the platelets were produced in the red blood in the bone marrow, but it's the clotting factors that are produced in the liver. Platelets are
Coagulation factors.
Yeah,
are produced in the
coagulation
liver.
factors are liver, but the platelets are produced in the bone marrow. All embryonic blood products, red blood cell, white blood cell, and platelets are all produced in the bone marrow. And then
Where are
other
platelets
elements.
produced? I'm positive it's the liver.
Okay, I found this on the web
No,
for
bone
where are
marrow.
platelets produced.
Why do I have that as the liver?
Because the platelets do not work without those clotting factors. Platelets are just garbage.
Oh.
They're just garbage. They're just floating garbage. They don't
Okay,
have
so
to-
it's like the angiotensin. It doesn't work without the
Yes.
ACE.
Yep.
Oh, okay.
And it's like T cells have to go to school in the
Okay.
thyroid.
So just really
to
quick,
learn
let's
their
go
job.
over the tests
Okay.
because I do have notes for the testing. So remember when she said that, like, let's say that you have somebody who-
D-dimer. Yeah.
it's heparin and coumadin.
Coumadin.
Yeah,
That's a blood. Yeah. It's a
so
blood thinner.
PT and INR test for coumadin, and
How do you spell that?
COUMADIN. But that's the spelling I have in my notes, and I always spell everything phonetically in my notes.
Coumadin.
whether it's spelled
It's a
correct
blood
or
thinner.
wrong.
Coumadin's a blood thinner.
Okay.
And so is heparin. So basically, coumadin is a pill and heparin is an injection. So both of those test for the drug in your system versus a D-dimer, which tests how fast your body clots. And then, and the reason why I remember PTT is because if you put the T's